Hello, I'm Dave Little, CEO of Scottish Drugs Forum, and I'll be chairing today's webinar on heroin assisted treatment. So thanks everyone for joining us this afternoon. The webinar will run to 5:30 and we aim to finish promptly at 5:30. Scottish Drugs Forum has for many years supported the introduction of heroin assisted treatment and encouraged debate on this service development through conferences with the sector and discussions with MSPs at cross-party group meetings in the Scottish Parliament. I think in actual fact, our first conference on heroin-assisted treatment was actually more than 20 years ago. We are delighted that the Scottish Government is supporting the rollout of heroin-assisted treatment across Scotland beyond the current Glasgow pilot. This will add another important intervention in our response to the ongoing public health emergency, which is Scotland's drug-related deaths crisis. There is a strong international evidence across decades that heroin-assisted treatment can impact positively on reducing harms and drug-related deaths, and this webinar aims to stimulate the development of service provision here in Scotland. In this webinar, we'll hear from existing providers of heroin-assisted treatment in Canada and the UK, and provide some guidance on the steps required to deliver local programs across Scotland. Today we'll hear from presentations from Angela Constance, Minister for Drug Policy, Scottish Government, Scott McDonald, Physician Lead, Crosstown Clinic, Vancouver, British Columbia, Eugenia Oviedo Yukush from the School of Population and Public Health, University of British Columbia, Carol Hunter, Pharmacy Lead, Glasgow HAT, Sakit Priyadarshi, Medical Lead from the Glasgow HAT Service, and finally, Danny Ahmed, Clinical Lead of the Middlesbrough Heroin Assisted Treatment Programme. We'll hear from each of the speakers in turn, and then we will have a question and answer session at the end. Austin Smith, SDF's Policy Officer, will join us for the discussion session at the end of the presentations, where he'll summarise audience questions, and I will put these to the panel. Questions and comments will also be shared with Government and the Drug Death Task Force as appropriate. So let's start with a presentation from Angela Constance, Minister for Drug Policy, who since becoming Minister has raised the profile and prospects of this treatment provision. Thank you, and now over to you, Minister.
Thank you very much, Dave, for that kind introduction, and I'm really pleased to be able to join you all here today and delighted to have the opportunity to open this very important event, and it's really encouraging to see the event so well attended. It's certainly evidence of all your dedication and commitment that exists across the country to ensure that we do more to support some of our most vulnerable citizens. You don't need me to tell the work you do is absolutely vital in our efforts to reduce the harms and deaths caused by drugs. So I very much thank you all for finding the time to be here today. In these last 6 months since my appointment as the Minister with responsibility for drugs policy, have been an important opportunity in terms of planning our next steps to tackle our drug death emergency here in Scotland. And the investment of an additional £250 million over the next 5 years will certainly assist us in our endeavours. We can all agree that Scotland has its own particular challenges when it comes to the issues of illicit drug taking. And in tackling this, we have to consider the wider socioeconomic issues affecting our communities, such as poverty, lack of opportunities, and to be frank, the lack of hope that exists for some of our people. And the recent Public Health Scotland statistics on drug-related hospital admissions have been a harsh reminder of the reality that many of our fellow citizens in the most deprived areas of Scotland are faced with. They are often in circumstances that are extremely challenging and sometimes chaotic, but it's our task to find better ways to reach people and better ways to support people with real choice and opportunities for change. And that's why I'm determined that we do everything in our power together to reach out and to create better pathways into better treatment. And I very much believe that heroin-assisted treatment can play a significant part in our work to both save and improve lives. We know a lot about HAT already. This is not a new approach. It has been tried and tested in many countries worldwide, including Switzerland, Germany, Austria, the Netherlands and Denmark, as well as being offered in the UK previously. So it is legal in the UK under specialist Home Office licence, and you will hear more about the two current UK-based HAT services in Glasgow and Middlesbrough shortly. And we know that HAT plays a key role in helping to create a safe space to address issues such as homelessness, mental health problems and access to welfare. And we know that the provision of good quality holistic support is the answer to addressing some of the multiple and complex needs of the most vulnerable people in our communities. Most importantly though, the evidence shows that HAT can help to reduce the use of street drugs and increase the likelihood of individuals engaging and remaining in treatment. And you will agree, I'm sure, that accessing and completing the right treatment is something that we should all be particularly determined to improve in Scotland. You will be aware that back in January, both the First Minister and myself committed to extending the reach of this treatment option across Scotland where appropriate. Further to this, I confirmed in Parliament last week that £400,000 has been committed in this financial year to start this work. And let me stress that additional funding will also be available in future years to widen the reach of this treatment option. So today I'm not here to tell you whether HAT is or isn't the right answer to deal with the specific challenges you are facing in your own area. This is a decision you will have to make, and there are many factors to consider. However, I do want to take this opportunity to thank Dave and the whole team at SDF for organising today's event and for inviting today's speakers who are key experts in this field. It is an excellent opportunity for all of us to hear about what they have learnt from operating HAT facilities, the different models used and what their advice is in terms of the steps required to deliver further programmes in Scotland. And it is their knowledge and expertise that will be absolutely crucial in allowing you to make a fully informed decision as to whether HAT might be an appropriate treatment to address the needs of some of the most vulnerable people in your community. However, what I can assure you of today is my commitment to support you in your efforts if you consider establishing HAT facilities in your area is an important way forward. In addition to the financial support I've already mentioned, I am of course more than happy to meet with anyone who would be interested in setting up such a facility and to discuss the details around this and to help to provide any additional information and support which might be helpful or useful. So I do hope you enjoy the presentations and the input from today's speakers. And I would very much like to thank all the speakers for taking the time to share their knowledge and their experiences to date. And I look forward to working with all of you at some point in the near future as we look to expand provision of this very important treatment. Thank you.
Thank you so much, Minister. That was a really helpful introduction and encouraging services to take this agenda forward. We'll now move on to our second speaker today, who is one of our two Canadian speakers, and we're delighted to have our colleagues from Canada join us, which is quite early in their morning. So we're very pleased that they can join us at this time. Our next speaker is Scott McDonald, who's the physician lead for the Crosstown Clinic in Vancouver in British Columbia. So welcome, Scott, and over to you.
Thank you for that introduction. And I'm happy to be here and have the opportunity to speak about our program here at Providence Healthcare's Crosstown Clinic. I just want to acknowledge that I'm today on the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and I'm grateful and acknowledge the opportunity to live, work, and play here on these lands. I have no conflicts to report. And it will be a short video. It's nice because it includes some patient voices, and it's always nice to hear how a treatment or a program is helping folks in their own words.
I met him at the injection site and he was heroin sick. And I actually had some and I took him and helped him. You know, and back then we were struggling. Your life just turns into, all it's about is getting well. Every minute of every day, you're either making money to get well or getting well. And I tried treatments, I tried everything and nothing would work. And you lose yourself. And the difference from then to today is we have our lives back.
Here at the Crosstown Clinic, we provide injectable treatment options for the most severely affected heroin users who have not responded to the typical treatments. The suffering from injection use of illicit heroin is enormous. The individuals suffer and society suffers as well. If people are not engaged in care with methadone and Suboxone, which are great treatments and work for most people, we need more treatment options, more tools in the toolkit. Not only is this treatment more effective than the standard treatments, it is also more cost effective.
It just brought me back, like, in touch with feeling like there was a way out, you know, a way to get healthy again and a way to feel human.
I hated myself many, many years. When I looked in the mirror, I didn't see me. I saw a person that did her hair. I didn't look at me. I just used the mirror to beautify myself to make some money for more drugs. Now I look at me, who I am, and I can smile because I like me today.
And I want to acknowledge our study participants and the patients of the Crosstown Clinic who've assisted through NAOMI, Salome, and our ongoing studies, as well as Dr. Eugenia Uberiotis, who will be following up this presentation. So just by background and introduction, opioid use disorder is a chronic relapsing disease. We have a number of effective treatments, including methadone, buprenorphine, sustained release opioid medications like Cadian that work, but they don't work for everybody and they don't work all the time. And there's growing evidence that injectable options with diacetylmorphine and hydromorphone here in Canada are effective treatment options. So NAOMI began here at this clinic in a site in Montreal. It was the North American Opioid Medication Initiative. It asked the question, is prescription heroin superior to methadone in that population that continues to use illicit opioids and heroin despite attempts at methadone and the standard treatments? It ran here from 2005 in Canada until 2008. And yes, it is superior, diacetylmorphine, prescription heroin, to oral options in that population. Published in New England Journal of Medicine in 2010. A Cochrane review was published in 2012, included 8 randomized controlled trials over 2,000 patients, and concludes that there is benefit in this population over just continuing oral treatment options. There is a benefit to adding in heroin-assisted treatment programs. And retention is improved, reduced street drug use, decreased illicit activities, possibly mortality, but we have Canadian data now showing that yes, there is a reduction in mortality, and I'll address that coming up. And we also have cost effectiveness data from our NAOMI study. Diacetylmorphine dominates methadone. That is to say, not only does it provide better care in the population that continues to use illicit opioid use, it also reduces societal costs. So our follow-up study was Salome, a study to assess longer-term opioid medication effectiveness. Unfortunately, we weren't able to transition to a program after NAOMI. The clinics in Montreal and here in Vancouver were shut down. But 10% of the people receiving injectable, 25 participants in NAOMI, were actually receiving hydromorphone, or Dilaudid, a licensed analgesic here in Canada. And there is a tremendous amount of regulatory and discriminatory barrier to diacetylmorphine and prescription heroin in North America that we are slowly overcoming. There may be less of that in Europe and in the UK, where it's been used for a long time as an analgesic. So Salome was designed to ask, is hydromorphone as good as diacetylmorphine, with the knowledge that hydromorphone may have less regulatory barrier and hurdles in North America that might prevent diacetylmorphine from being made available broadly. That's the advantage of hydromorphone. It is a licensed analgesic. So we selected patients who were at least 5 years using opioids at 19 years of age, having at least 2 episodes of opioid addiction treatment, one of which had to be methadone, Suboxone, or substitution treatment, and physical, psychological, or psychosocial consequences of their opioid use. The folks that we selected were older, mostly male, and had on average 15 years of injection opioid experience and had tried treatment on average 11 times. So exactly the folks that would be appropriate or we might want to recruit into a treatment like this. So this is a quote from one of our PhD students, Kirsten Marchand, one of our patients who reported that what they benefited most from was most important to them was that the medication, because it stopped the need for other things, not needing to go and buy street drugs, not having to go and do crime. Like I said, I always had charges. I was in and out of jail all the time. So one patient's voice and why this treatment worked for them. So this is a slide that shows number of days of use in the prior month of opioids, or number of days that street opioids were acquired, versus the 6-month treatment phase in NAOMI, or Salome, sorry, with either hydromorphone and diacetylmorphine. And the treatment effect is not different between the two. When people started, they were using street opioids basically every day, and by 6 months in care, that goes down to a handful of days, less than 5. So that just demonstrates in one slide why this is such an effective treatment. Our average dose of diacetylmorphine is just over 500 milligrams and just over 200 milligrams. This is interesting to me because people start and their doses go up over the first few weeks, but then they level out. There isn't no escalating over time. People get to a dose that works for them. And in fact, over time, people take less than is prescribed. So now, thanks to Nick Bansbach was our health economist, and thanks to him for these slides in this study, which gives the analysis and modeling from pooling the NAOMI and Salome data for people who received hydromorphone, injectable, and methadone, and was able to conclude that providing injectable opioid agonist treatment, either diacetylmorphine or hydromorphone, adds 2 to 3 additional life years or 1 additional quality adjusted life year over just continuing methadone. This is a lifetime analysis model, but from this we can conclude that providing heroin-assisted treatment or IOT, we reduce mortality. And in addition, most of that cost savings is in the criminal justice system, and providing IOT reduces per year to 6 property crimes versus just continuing methadone. So a reduction from just providing methadone of 15 crimes per year down to 9 crimes per year. So we can also say that providing IOT reduces crime, both property crime and violent crime. So this is the reference, Nick Bansbach, the lead author, published in Addiction. And if somebody's interested in our cost effectiveness analysis, which also shows reduced mortality and crime, this is the reference. So just to sum up on Salome, Prescription heroin and diacetylmorphine, where it's not available, hydromorphone could be offered as an alternative. That may be more relevant here in the North American context, but it also provides support for the supervised model of care, which is the model that's being used here in Canada, it's in Switzerland, and I understand in Glasgow and in Middlesbrough. So opioid agonist treatment, it's safe, it's effective, it's cost effective, reduces mortality, reduces crime. There's no controversy here, folks. This is something that should be considered and expanded where it is needed. So just in the BC context, we had a public emergency declared here in April 14th of 2016 by our provincial health officer. And we've had slow expansion of a number of interventions, including injectable opioid agonist treatment, but it's still small and not having the effect that we'd like to see. I remain optimistic. We now have injectable opioid agonist treatments across Canada. So 5 out of 10 provinces, from British Columbia, Alberta, Ontario, Quebec, and New Brunswick. There's 4 clinics out of those that offer diacetylmorphine, the prescription heroin. That will be coming and expanding as well. It's just slower than I would like. So just to sum up, SIOAT, supervised injectable opioid agonist treatment, reduces mortality and it's cost saving. It's a treatment option for those who continue to use street drugs with all the risks that entails, injecting-related infections and overdose. It substantially reduces people's need for street drugs, reduces crime, and leads to more engagement with healthcare and allied services. And where diacetylmorphine is not available, hydromorphone or Dilaudid may be an alternative. And that's just outside our clinic. Here's a picture of our nursing clinical coordinator, Kelly Harper. I just want to highlight that it's really the nurses here at the clinic that do all the hard work. This is a nurse-led intervention. I'm happy to be here and support them. But just in the next room, it's our nurses that are greeting all of our patients as we speak and getting them the care that they need. Thank you.
Thank you, Scott. That was great, and admire your optimism, which of course we all need to hang on to. And in this context, we're hopeful that we can expand in the way you have done. We can now move on to Scott's colleague, Eugenia Oviedo Yukush. Sorry, I got it wrong. I got it right before, but not now. Sorry about that. But welcome, and over to you. Thanks, Eugenia.
Good morning for me. Good afternoon. We are very happy to be here. You will hear me talking about we, because every time I present, like Dr. Scott said, there is a lot of people. I stand in the shoulders of a lot of people, and for sure on the clients, patients, participant members, there's always nuances on how we name the clients. So yes, I think it's time to accept injectable opioid treatment as part of the continuum of care. I would like to acknowledge with humility and gratitude that I live, work, and play on the traditional, ancestral, unceded, and occupied homelands, the Coast Salish people, including Musqueam, Squamish, Tsleil-Waututh, and Solo nations. Before I get a bit more on the treatment that we provide, I would like to just give you an idea of where we are at, very, very briefly. As Dr. Scott mentioned, we are here in Canada and the US in this tremendous overdose crisis. And it has increased or not changed. This is not getting better. And we have many interventions that have expanded across Canada, like supervised consumption sites, overdose prevention sites. There are nuances between them. I'm not going to expand on that. Naloxone distribution, and together with opioid agonist treatment, it is estimated that those interventions have saved many lives. Injectable opioid agonist treatment is expanding slowly. And the slowly part is mostly because there are regulatory barriers, and in the way that sometimes it's provided, it doesn't make it easy to sites to set up. The overdose death attributable to prescription opioids have not decreased proportionally to the dispensing of the prescriptions opioids. And this is data that we have from the United States. And I want to bring this up because sometimes people think that it will be one approach that is going to help the overdose crisis, but the number of outpatient opioid analgesics prescription dropped 13% nationally, but the overdose death only has increased. So I want to go through the core aspects of how IOT is delivered, and I will use the IOT, that is injectable opioid agonist treatment. The medication is dispensed and self-administered by injection under the observation of nurses or other qualified personnel. There are some sites that are trying to be more flexible in this provision when we try to have nurses and other qualified personnel, and this is daily. This observation is to ensure the safety of the clients. If something happens, we are there to help with, for example, dose intolerance, but there are other side effects of the medication. And also the community, because sometimes when people have these medications, they can be victimized by others, and other times other people might be exposed to these medications that were dosed and prescribed by the clients, and if other people use it, might not be the most adequate. In those moments, it will be very important for us to capture those, as people might be needing treatment and they're not being reached. For some, injectable diacetylmorphine and hydromorphone seem to provide enough motivation to attend and engage into care routinely. These daily visits are core to allow nurses, staff, and clients to build and maintain relationships. These daily visits provide this space where we can build relationships and then work on maintaining them. This approach to care provides a tremendous opportunity also to offer comprehensive care and connect people with services. This is also something that we cherish very much, how we can connect people with the other services they might need. And we use that space to build and maintain those networks. So the delivery of the medication matters. And I was so pleased to hear from the ministry when she said, we know this treatment works. This is nothing to be contented about. The theme now is how. And for clients, the delivery matters. People are forced into the illicit stream of drugs because they can't get legal access to meet their needs. So you might want a specific medication and that is not available through the system, or sometimes it's the formulation. You might want to inject and that's not available through the system. So they have to lean on the illicit stream of drugs. So for that, we have to put our beautiful hat of patient-centered care. And we try to honor patients' preferences in the medication they will choose to take, the setting, and the format of the treatment. Because if we make this treatment so difficult to access, it doesn't matter if we offer diacetylmorphine. We are going only to capture a very small group of clients. These are sometimes limited by restrictive regulatory systems, structural vulnerabilities, and lack of providers training in PCC. Sometimes the providers have not captured the idea that we are trying to do our best to meet the diverse needs of the clients, and they focus sometimes too much on the medication themselves. So this over-reliance or restrictions of the medication impedes effective responses. So when we work in IOT, we try to understand that without the right medication, we won't capture the attention and we won't be able to connect with the clients. But at the same time, the medication is just part of what we're doing. And we have to understand the complex interconnections that people are living with, like, obesity, disability, chronic pain, depression, poverty, incarceration, all that interconnects and interacts with the treatment we're providing. And just I think my penultimate slide, if I'm not wrong, this is what we are building over the years with our team and all the minds that we put together and what we're seeing. And I would like you to focus first on this greenish in the back. This is the site that we try to offer the treatments, and the medication is in red. accessing the site, they will access to the medication. There is no line here. Medication is key, but it's not all of it. Once people access the site, we have all the work that we do inside, the building and maintaining trust, providing individualized care with a patient-centered care approach, developing and maintaining relationships, and then there are other services, and other services can be inside the site, but they're also outside the site, and that will depend on how you are going to set up your site. Sometimes there are sites that need to be very, very minimum because that's what the clients need. And then the most important job will be how you are connected with the outside world. And then there is the life outside the site when we try to provide the patients with as much autonomy they can so they can have the agency of self-care. Finally, the future planning. Some clients are aging out and how this is going to look like in the future for them and how this continue. We have clients, for example, in Spain that have been receiving injectable for 20 years since we started, and how the life continues. And across all this, without the intersectionality of sex, age, ethnicity, let's not forget geography. There's some places where you have to make this treatment way more flexible because geography is not going to let you have a site with the same characteristics that you have in an urban setting. And in our closing, we are advocating for injectable opiate treatment to be normalized. And new approaches of sites need to be part of the continuum of care, meeting a patient-centered care standards to support individualized treatment and intervention plans. This is very important to have a diversified range of medications so you can, as a provider, have a shared decision making that is going to meet the client's needs. It's very difficult if you have one or two options and in the flexibility on what you can do with the medication, where you can be providing the treatment. And my last thing to put in the people's head is, let's think also about what our outcome measures. They also need to be patient-centered. It's not just about urine screens and retention, but it's also about quality of life and continuation of care. What is meaningful to the clients in terms of how we assess if this treatment is working or not working. And how I conclude, I'll also acknowledge the clients that are the most awesome people, and they work very hard, and they come 3 times per day to receive the medication. They're very committed to the treatment, and we should be doing better for them. Thank you. Merci. Gracias.
Thank you so much for that presentation. And just to remind our audience that we will have a Q&A session at the end. So if people can, continue to submit questions during the presentations. But thank you so much for now, and we'll hear from you at the end. Thank you. And if we can now move on to our local speakers. Firstly, Carol Hunter, who's the pharmacy lead for the HAT service. Thank you, Carol.
Thanks, Dave, and thanks for the invitation to speak to you all today. That was really interesting from Canada. I'm from a bit closer home. Now, developing an enhanced drug treatment service, which is what we call our HAT service here, we had 6 main work streams. I'm only going to focus on the ones in the middle there, the licensing and the pharmacy aspects. Saket's going to deal with all the exciting clinical patient-centered elements of this service. But as a pharmacist, I was asked today to speak about what is essentially the very dry technical detail that's needed to establish this type of service. However, it is essential, but it's not nearly as exciting. What I'm planning to cover today, I've got a fairly short period of time. I'm going to look at the licensing for the site and the prescriber, say a bit about the product, the dose preparation, a bit about a risk assessment and how we've arrived at the model we have in Glasgow today. Now, the Controlled Drugs Accountable Officer, this is a key role for any HAT service in Scotland. It's a relatively new role and it's got significant responsibilities for the management of controlled drugs, and I've listed these statutory responsibilities on the slide there. That role was introduced as a direct result of the recommendations of the Dame Janet Smith inquiry into the Shipman case. And if I could give any advice, what it would be is anyone considering a HAT service in Scotland needs to consult and include their relevant accountable officer from the very earliest stage. We did obtain our Home Office licence in March 2019. And first of all, you have to have your premises and your standard operating procedures in place before you apply for this licence. And there's full directions there on the Home Office website about how to apply. We had a project manager, and he has produced what is a very detailed step-by-step guide to the licensing process, and I'm happy to share that with anyone. It does cover all the aspects of the and in order, and some of the timescales as well. So once you have the Home Office licence for the site, then you can apply for the prescribers' licences. Now, these powers to issue the licences were devolved to Scotland in 2012, and these are powers under the Misuse of Drugs Act. Now, I know we're not here today to talk about supervised drug consumption facilities, but I think it's worth noting that the precedent is there that an element of the Misuse of Drugs Act has previously been devolved to Scotland. The point to note is that the Health Board makes the application to the Scottish Government on behalf of the doctors in the service. It's not the individual doctor themselves. And this doesn't extend to any non-medical prescribing. The licence covers medical prescribing only. So the Controlled Drugs Officer, Accountable Officer, and the Health Board's Medical Director, they assess that the service can be provided locally in a safe and secure way, also that it's clinically needed and that the doctors are appropriately qualified. So these checks are all done initially at the Health Board level, and then the Health Board submits that application to the Scottish Government. There is no doubt that product choice is extremely limited, and there's no one ideal product. What is used is dependent on the facilities and the staffing groups available in each service. The UK licensed product here, that's available for use but only in single ampules, and it is available in a range of strengths. However, just a word of caution, that product has been subject to repeated disruptions in supply recently over the last few years, and the most recent medicine supply alert notice, I think in April 2020, noted that the two suppliers of the 5 and the 10 milligram strengths say that the continued supply is likely to remain unpredictable for the foreseeable future. And the 30, 100 and the 500 milligram strengths are available, but manufacturers are unlikely to be able to support an increase in demand on these strengths. This is the Swiss product. It comes in a 10-gram vial and it has to be reconstituted. This is the one that we use. It does require a pharmacy resource, whether that's on site, as we have, or from an external aseptic unit. That allows us to prepare in advance multiple doses from the 10-gram vial, which you can't do with the UK product. So far, at the moment, our service has a maximum expiry date on the prepared doses of 7 days. Now, I very deliberately haven't included any costs in the slides, as there's so many variable factors that affect that. It's somewhere in the region of between £5,000 and £15,000 per patient per year, but that's dependent on which product you use, how it's prepared, the number of patients, the doses prescribed, and more importantly, the level of wastage. So once you've decided on what is the most cost-effective, the relevant product that fits the service model, then that leads us on to dose preparation. This is a bit more of the boring technical bits, but the EDTS model we have only meets the first 4 criterion. The preparation facilities we have in EDTS consist of a bench-sited laminar airflow cabinet within the dispensary area, and that has what's termed an unclassified background environment, which is not fully compliant with what's defined NHS guidelines. So although we don't fully comply with the Section 10 exemptions, and I think probably at this point it's worth noting, none of this is specifically about diamorphine preparation. It's not designed to make a heart service, although it feels like it at times, it's not designed to make a heart service difficult. This refers to the reconstitution of any injectable medicine for any patient in any setting. And our patients obviously have the same right to the same standards as all other people who are prescribed medicines in this way. This is, I have to admit, this is not my area of expertise. I work in the drug and alcohol field. So that's why you have to include and consult with your colleagues who work in aseptic preparation and quality assurance, and also CD governance. The risk assessment that we did followed a fairly standard risk assessment matrix, and this was at the request of our accountable officer. It was very thorough and looked at a wide range of potential options and also risk mitigation factors for each of those options. I don't have time to go into the full risk assessment or the other options, but I am happy to share that assessment with any area that's looking to develop their own service. The agreed risk mitigation strategies we have in place in EDTS involves staff training, regular monitoring around the background environment and the sterility of the product that's produced. So built into the risk assessment also has to be the risk of not having the service, and I think that might be a unique part of our risk assessment. As a result of all of that, what we ended up with is something that allows us to provide a responsive, flexible, patient-centered service. We dispense directly to the patient, leaving our nursing staff free to focus on the patient through pre, post-injection areas and to supervise and support them through the injecting process. We have internal prescriptions and dispense other medications, including methadone, antibiotics, antiretrovirals, and all of these can be whether they're prescribed to be consumed on site or dispensed as take-home doses. And you can see the dispensary hatch there in the middle, which patients directly access from the supervised injecting area. And I do think we need to remember that this was only a heroin assisted treatment program was only one of the recommendations of the Taking Away the Chaos report. So the HAT is not a service that sits in isolation, but it's part of a comprehensive response. This guidance was published by Public Health England in March this year. It's an important and comprehensive document. So apart from the prescriber's licence, which I've explained is Scotland specific, all of the other legislation and the professional guidance applies UK-wide, and it's essential reference for any area looking to introduce a HAT service. This is my last slide, and in summary, this is not an easy service to plan or deliver. You need to identify the needs of the population and also your site. There's definitely no ideal product as yet. And for nurses and pharmacists, it's difficult to comply with the guidelines. However, we can't ignore them. We were very fortunate to have had an excellent project manager. And I think that's particularly important for anyone developing this service, that whoever's performing that role fully understands all the legal and professional requirements around the licensing and the product. And I would certainly encourage anyone to contact colleagues, and it's been really helpful to hear from our colleagues in Canada today. For us, the team from the Riot Trial in London were very generous with their time and advice when we were setting this up, and that was extremely helpful in making us aware of the challenges and some of the pitfalls and how to avoid them. So my email address is there if anyone wants to contact me directly, and I'm happy to share both our step-by-step guide to setting up a service and a risk assessment that covers in a lot more detail everything that I've mentioned today. And that's all from me. Thanks.
Thanks so much, Carol. That was really helpful to have all of that background for the delegates today. So thank you so much for that. I'll now ask Sakit Priyadarshi, who's Carol's colleague, who's been working also on the delivery of the Heroin Assisted Treatment program. So can you join us now, Sakit? Thanks.
Thank you very much, Dave, and thank you very much to Carol for leaving me the exciting stuff. But Carol, we couldn't provide the clinical services and do the exciting stuff we do if you and your team didn't do the boring stuff so well. I work a day a week in the enhanced drug treatment services where we provide heroin assisted treatment. And I'd like to begin by acknowledging my multidisciplinary team, my colleagues who are providing those services, the team that helped implement heroin assisted treatment in Glasgow, my academic colleagues who are helping us evaluate that service, and of course the first cohort of patients receiving heroin assisted treatment in Scotland, about whom this service and this presentation is really about. And as Carol said, we implemented heroin assisted treatment in Glasgow in response to a health needs assessment of people who inject drugs in public places. This is our injecting area of our enhanced drug treatment service in Glasgow, and you can see why potentially this environment is much more preferable to the public injecting environment and would produce more positive results and better outcomes for people who use drugs. Our service is a pilot service. It's undergoing an evaluation, and we'll be presenting the findings of that evaluation to our Alcohol and Drugs Partnership and our Integrated Joint Board in due course. However, suffice it to say that at this stage, we're already seeing, though not for everyone, for those who respond, quite significant improvements, which some clinicians have described as profound, and a patient yesterday told me was phenomenal for them. And we can see from the early data emerging from the evaluation that it is showing very positive results in terms of outcomes for those who have engaged to date. So this is the reception area of the heroin assisted treatment service. It became operational in December 2019, and we had hoped that by the end of the first year to have engaged 20 people into treatment, and by the end of second year, about 40 people into treatment. But this virus, the coronavirus, has, as you know, caused a pandemic and affected our services just as much as it has any other health and social care service. So unfortunately, we've not been able to recruit to the treatment nearly the numbers we had hoped. And at the moment, we've provided services to 16 individuals to date. The service was suspended for about 6 weeks last year in the middle of the height of the first wave of the pandemic, but we were able to engage all those individuals in the service and restart treatment in due course. And the people that we have engaged in treatment are, as you can see, people with very significant complex needs. We've looked at the baseline of the enhanced drug treatment service patients and compared them with the baseline of the randomized injectable opiate treatment trial, RIOT trial that was done in London. And you'll see from this that our patients in the EDTS have a longer length of drug use. They've spent longer time in treatment, other treatments before coming on to injectable opioid treatment. They have very high levels of cocaine and crack use. All of them have experienced homelessness just prior to coming into treatment, and they have very high rates of incarceration as well. The benzodiazepine use was surprisingly similar between the RIOT group and our baseline, but actually I think that's perhaps misleading because it may be that etizolam wasn't recorded under the benzodiazepine heading, and all of our service users, almost all of our service users, were using etizolam prior to coming into treatment. And I'm going to talk a bit more about that in due course. What we've learned from taking patients in, that it is possible to recruit to heroin-assisted treatment in the real world using non-research-based criteria. And when admitting people with complex needs, as I think our other colleagues have mentioned earlier, as well as focusing on the clinical elements of care we want to provide, we have to actually follow the patient's service users in terms of what their priorities are. And undoubtedly what we found their priorities are around harm reduction, safe injecting, for example. So this is a vein finder that helps prevent wound infections, but we do regularly treat wound infections. We dress them, prescribe antibiotics, we're providing injecting equipment provision and naloxone as required. And actually, and certainly in the early stages of our engagement with our service users, the needs are fairly basic. They need food, they need welfare rights, and to sort out their finances. And we've worked very closely with housing providers, and particularly with the Housing First team that we're co-located with in supporting the housing needs of our service users. So none of them now sleep rough. They all have a roof over their head, and many of them now have keys to their own accommodation for, well, some of them for the first time that they can remember. The service is open 7 days a week, 365 days a year, and there's undoubtedly, you need to know that the staffing requirements there are very significant. So a lot of resource required to run a service like this. This is my team of medical doctors who provide on-call services at weekends, talking to our pharmacist at the service. So as well as having enough staff, you need staff who are experienced and clinically confident. They also need to be able to manage risk and uncertainty. But most important, they need to be able to engage and build therapeutic relationships with a population that has had an experience of adverse childhood events, complex trauma, and has had difficulty engaging with other health and social care services in the past. This is particularly true for the nursing staff who, as Scott McDonald earlier described, really are at the very front line of engaging with this group of patients. And our nurses often find themselves having a front row seat into really quite difficult, precarious and high-risk life of the people that we are trying to engage and improve the circumstances of. As well as having enough staff and the right type of staff, it's very important that services supervise and support their staff as much as possible. And we dedicate some of our psychologist time to that role of providing staff support. Back to the clinical elements. With careful assessment and a little bit of bravery, it's absolutely possible to titrate people carefully as well as quickly to doses that they require. And we found the doses very, very similar to what Scott McDonald showed earlier. Most of our patients require somewhere between 400 to 600 milligrams, many of them currently on more than 500 milligrams of diamorphine a day. However, one of the challenges we've found is the management of etizolam on top of injectable opiate treatment. So unfortunately, etizolam is easily available and seems to be the drug of choice, particularly relapses that are related to psychological distress. Point of care testing is really unhelpful as we don't have a point of care test for etizolam. We have supported our local lab to be able to provide us with etizolam results, but that does take some time. Pre-assessment checks are really essential in injectable opiate treatment, but there is a small window of time between taking etizolam and presenting where the patients can present very well. And when they take the injectable opiate treatment on top, it can produce really quite profound post-dose sedation. And the three adverse events we have had have been linked to that and have required naloxone to reverse overdoses. Etizolam, we find, is also the main contributor to missed doses and complicating titrations. We managed to turn things around, keep engaged with folk, and then it takes a few hard weeks of work to get people back on track and back onto injectable opiate treatment at the doses they need without etizolam use and making progress again. When implementing injectable opiate treatments, it's very important to ensure that you have correct interface with local inpatient and residential services. So the Glasgow Royal Infirmary for us, Barlinnie Prison, and the Glasgow Drug Crisis Centre. This is to ensure that patients and the staff working in these services are absolutely clear about what to do and what to expect when they transition from our services into one of these inpatient or residential areas. So the licensing for injectable opiate treatment is only for the clinicians and the service at Enhanced Drug Treatment Service. So when people are admitted to the Royal Infirmary or to Barlinnie or to the Glasgow Drug Crisis Centre, for example, it's the oral methadone treatment which is adjusted to compensate. It's also important to say that these other services it's very useful to be able to reach into these services to engage people into injectable opiate treatment who are sometimes difficult to find, even with good outreach services in the community. So just in conclusion, the working in the enhanced drug treatment service is really quite an intense and at times challenging role to do, but it's hugely rewarding because although a slow and winding road for many, those who do engage with this treatment actually make quite remarkable progress that they haven't made in other treatments before at all. And as I'm going to conclude by saying just what Carol said at the end of her talk, which is that please don't feel that you have to reinvent the wheel when you're looking to implement injectable opiate treatment. So we lent heavily on our colleagues in London and in Switzerland to develop our prescribing guidelines, our interface documents, our operating procedures, and our service spec, and we'd be delighted to share any of that material with you. And in fact, very recently, we're becoming involved in a UK-wide network of HAT providers, and it would be wonderful to have another Scottish service join that. Thank you very much.
Thanks, Saket, very much for that, and that's a great offer to end on, I'm sure. Well, I hope you'll be taken up on that later on. Our final speaker is Danny Ahmed, the clinical lead of Middlesbrough Heroin Assisted Treatment Service. So thanks for joining us, Danny, and over to you.
No problem, thank you. Thanks for inviting me. So just to add context, really, a lot of people often ask why Middlesbrough and why now? And I guess there's a few reasons for why Middlesbrough looked at this treatment option. But first of all, it's one of the most deprived local authorities in England, with 49% of the areas of Middlesbrough falling into the most deprived category. When you put that with the large level of opiate users that are live in the town, you can see that per head of population, we've got the highest level of heroin users in England. And further to that, Middlesbrough unfortunately continues to consistently report high levels of drug-related deaths, and all of the areas in yellow are surrounding areas to Middlesbrough and part of the Tees Valley, all of which continue to see rising levels of drug-related deaths and harms. We started in about 2017 planning our service and looking with the public health team, and similar to our friends and colleagues in Glasgow, we looked at the introduction of heroin-assisted treatment and drug consumption rooms as part of a wide approach to address the needs of people who use substances in Middlesbrough. We focused on heroin-assisted treatment because the work stream for drug consumption rooms was impeded by the current legal situation in the UK. And we had a lot of work to do to really understand how could we bring heroin-assisted treatment to Middlesbrough. And that involved initially some field visits. I was very lucky to visit Scott's service in Crosstown and services in Switzerland. And they were vital in helping us understand some of the operational challenges and the day-to-day runnings of such a service. We needed to acquire the appropriate licenses. The licensing process in England is similar to the Scottish one, but we apply to the Home Office directly for our doctor licenses. The premises licenses, I believe, is exactly the same process as Carol outlined earlier. One of the big hurdles for us was acquiring our funding. And again, that's a difference that you may have certainly moving forward in Scotland. And we worked with the Police and Crime Commissioner, who was very forthright in pulling together a partnership to agree funding for a 1-year project. And that was a combination of funding from probation, from the local prisons network, our public health team, and the Office of the Police and Crime Commissioner. The 2nd-year funding for our project came from proceeds of crime. So organised crime gangs, a percentage of their proceeds sit locally, and some of that was used towards funding our programme. We engaged in a kind of media campaign really to start to address the need for heroin-assisted treatment and why that was important to the local community. And probably one of the mistakes that we made is continuing to use the language of heroin-assisted treatment rather than, as we've seen in both Canada and in Glasgow, a more generic name. I think that's led us to have some more controversial headlines that we could probably have avoided. Our aims and outcomes are there for you to see, but our primary outcome was a cessation of street heroin use. Could we disrupt that relationship between heroin use for the individual? Because we felt if we could do that, that then the other outcomes would fall out of that disruption. And that would be similar to the trials, the Rio and the Riot trials that had taken part in England previously. In terms of patient selection, we looked at a range of factors. Again, it's very similar to what you've heard already in the previous presentations. But we effectively looked at a cohort of individuals that were identified as failing to benefit from the traditional treatment offer, had standard treatments that had not been successful before. We then started to examine data from primary and secondary care to see individuals who were clearly struggling with their health or having repeated overdoses or problems with wound care and so on and so forth. And we added in, working with our criminal justice colleagues, exploring individuals who were known to be still criminally active. And when we started to bring those lists of names together, we could see that there were a number of people that their substance use was impacting their whole life, as you'd expect when it was quite chaotic in its nature. So we went live in October 2019 and been operating for about 18 months. Patients are attending twice daily for the administration of medication. And again, as has been mentioned before, ours is an integrated service. So an element of our GP practice, we're a specialist GP practice that services people with substance use problems. A small section of the practice, a couple of rooms, has been dedicated to heroin-assisted treatment. The reason that we did that is that we wanted the service offer to be integrated into the treatment system. So the psychosocial offer, the care coordination offer, the health offer that is available to everybody was available to individuals on HAT. So this effectively became just another treatment option that was being delivered from the building that was traditionally used for all of our kind of treatment offers for people who are struggling with substance use. Doses in terms of medication are very similar to what's been mentioned earlier, and as Sakit mentioned, one of the key difficulties that we've had is the use of street tablets. Middlesbrough particularly has a liking for street Zopiclone, and that certainly has caused us some problems, like the Atazolam problem that's been mentioned earlier, in terms of disrupting somebody's stability in the programme. We've currently got 8 patients on the programme. Our recruitment is suspended, and we've had periods of suspension of recruitment throughout the 18 months, primarily for COVID. And as was mentioned earlier, that's had a significant impact on our ability to deliver the programme and deliver it in the way that we hoped to. Secondly, we had to make a switch in medications, which I'll talk about later, and that's increased our costings unexpectedly. And right now we have uncertainty over our funding. So our funding runs until September this year. And we're at the point now where it's really not a bit of a benefit to get somebody on a program that they're not going to be able to be on for more than a couple of months. So we're hoping to get that funding acquired, and then we can restart our program and the recruitment. For those that are on the program, this is an example of the drug screens that we receive, and you can see in these examples that the drug use is stable, and we have really good treatment concordance. So what we are seeing is that is people literally coming alive and living lives that they're with stability that they've just not been able to achieve before. And Carol spoke quite a lot about the issue around medication and there not being the perfect choice. And we're in that dilemma of choice now. We began with a multi-use vial, and we prepared that medication similar to as we'd seen the medication prepared in the Swiss clinics. And the recent guidance has made it very clear that the expected conditions for that medication is full aseptic conditions. So we've moved away from that product right now and onto single-use amps. Single-use amps are more expensive as a product, but they have a flexibility of use in that nurses can prepare those, whereas the diaphin needs preparation in particular conditions and through a pharmacy department. So you have some questions to think about around medication. Do you follow the Glasgow example and have a pharmacy department that on site that is able to give you that flexibility of the medication? Do you look at using single-use amps, which has a different costing per medication, but gives you the flexibility of using your nursing team? Or as we're looking at, do you look at a question between on-site and off-site preparation? If Scotland as a country is in a position to look at a central hub of distribution, that may be one way that medications could be prepared off-site at the doses you require. So there are a number of questions to really think about when you consider the medication that you're using. Our program has been independently evaluated, and that has now been published. I'll come on to some of the findings of that in the next few slides. But we're also onto our second piece of research, and that really is a collaboration between Teesside University, Durham University and the London School of Tropical Medicine. And what we're hoping to do is explore the experience of individuals who've either completed, discontinued, or have decided that HAT wasn't the program for them. We're going to explore that as subjective kind of experience. What is it like to be in a HAT program as an individual? What the rationale that people decide that they don't want to get involved in a HAT program. I know that we're linking in with our friends in Glasgow around this piece of research. So it'll be really interesting to see and get that feedback from the people that we serve. And just looking at the independent research, the research looked at 4 key areas and added a 5th because COVID was such a significant event that it needed to be considered in the evaluation. So this period of time for our research was over 1 year, from October 19 to October 20, and we saw 14 people in that period, 85% of them being male, and just over half continue to receive treatment. We had a small number who took a break from treatment, and we had 3 people, 2 who were committed crimes and returned to prison, and 1 individual who left the area. What we did see is a high level of engagement, so 97% of the dosing sessions were attended, which for a group of individuals who were struggling to engage with any agency at any time, they were people that we were not seeing unless they were in crisis. Attending twice daily to these appointments has been quite a remarkable level of behaviour change. We've also seen some individuals move to a reducing dose of dimorphine. So some individuals have moved to once only daily dosing. In terms of street drug use, importantly, we've seen no drug-related deaths, and I think that is important for us to consider when we're looking at this high-risk group. Many people have managed to maintain their abstinence, so we've got an 80% reduction in street heroin use. So every client that came in to the service reported that they were using heroin 28 days out of 28 prior to coming into the service. And as you can see, the 80% of individuals have managed to break that cycle. We also have a number of clients who, although they haven't completely abstained from heroin, their level of use is significantly reduced to ad hoc use rather than being habitual daily use. We've seen an increase in the psychosocial interventions that individuals engage with. So by month 10 of our research, everybody was reporting that they were engaging with some sort of PSI. And that wasn't a mandatory part of the program, but it was available and around the participants every day of the week. Some individuals have got involved in groups, some individuals have got involved in mutual aid, others are just having more contact with their care coordinator, but everybody's reporting that they are taking part in PSI. As part of the evaluation, we measured individuals' well-being, as was mentioned in some of the earlier presentations. We used the Edinburgh Wellbeing Scale and we used the treatment outcome profile. Looking at the Edinburgh Wellbeing Scale, we saw that individuals reported basically scores that would be classed as probable depression. Within 1 month, the scores increased to be on par with the general population. By month 12, the well-being is reported as being above the average for the general population. In terms of the TOPS self-reported outcomes, we saw a 100% increase in individuals reporting their physical health had improved. A 261% increase in people suggesting their psychological well-being had improved, and a 218% increase in terms of individuals suggesting their quality of life had improved. So a really dramatic change in individuals' perception of their own well-being. We've also seen an improvement in secure housing. So on entry, the majority of patients were in secure housing and 4 of them were street homeless. Everybody's housing situation has improved as being part of the HAT program. That's either that they've moved to secure housing and nobody is reporting being street homeless since being part of the HAT program. Crime was an important indicator of our program, given that the majority of the funding came through the criminal justice system. And we, as we heard from Scott earlier on, there is a definite impact on criminal behaviour when individuals become involved in a HAT program. So we saw that our group was characterised by long-term entrenched offending behaviour with an average career of about 19 years and a total accumulated prison time of 52 years with an estimated cost to the Ministry of Justice of around £4 million. When the team at Teesside measured 1 year prior to HAT and 1 year on HAT, they saw a 60% reduction overall in criminal behaviour. So there was a definite impact. And the rate of offending per person moved from a ratio of 3-to-1 offences to 1.2 offences per person. So we know that we can make a significant impact on the criminal behaviour of individuals in a HAT program, which has a profound impact on the community. And here's some feedback we've had from a range of individuals who've had contact with our participants, from health workers to police officers to community workers. And I'll leave you at your leisure to read those when you get the slides sent to you. And I just want to end, next slide please, with the words of James. And James is one of our participants.
I want to be total abstinent of everything, and then I could probably help other people do it, because I've been through it and I know what the problems are. I don't know exactly how to deal with them, but I know how you can start to sort of deal with them. This might not work for everyone, but it's worked for me and it's worked for the other people that I'm on the programme with. And like I say, we've been given a chance for a lifetime, and you can see the difference in everyone, I think.
Thank you very much for your time, and thanks for inviting me.
Thanks very much, Danny. Can I ask all the presenters now to come back, and we've got a little bit of time for questions. Can I just say we've captured obviously a lot of questions, I'm sure, and our intention would be to try and answer those, you know, maybe after the webinar as well in some way. So can I introduce my colleague Austin Smith, who's been collecting all the questions, which I guess in 10 minutes we're not going to be able to answer them all.
Yeah, I think that's true, Dave. So I've compiled, I mean, this doesn't even begin to cover it, but I've made up one question which consists of 5 parts. So maybe people would like to select the bit that's appropriate for them. But the question is, what supports are needed to develop local momentum to deliver HAT across Scotland, and what lessons from Canada for that? Who are the essential key contributing stakeholders? How can we stimulate interest from clinicians, prescribers across Scotland to look at developing the programme? And this came in a few questions. People made a point about rural settings. Is this achievable in rural settings? And if so, how might a service be developed that was suitable for a rural setting? And a lot of that was about people attending 2 or 3 times a day. How was that? If people are travelling, what does that look like?
Okay, Austin, can you repeat the first one first, and I'll ask someone that one rather than try and remember all 5, which is beyond me.
Yeah, okay. So the first part is what supports are needed to develop local momentum to deliver HAT, and I suppose who are the essential key contributing stakeholders?
Okay, Saket, can I give that to you as the key local person alongside Carol, of course?
Yeah, maybe Carol wants to come in after me. Remember that, as Carol and I both reminded everyone, our treatment service, although we've identified heroin assisted treatment as a gap within our system of care for a number of years, it was really a formal health needs assessment that made a recommendation to the Alcohol and Drugs Partnership that allowed us then to build on that recommendation and build a business case around that recommendation. So it clearly identified a group of people who would potentially benefit from this treatment, who had had other treatments previously. So that's one model and one way of doing things, but that's not necessarily what happens everywhere else in the world. So even in Switzerland, there are some services that run that sort of tiered system, but other services run a much more lower threshold, more open access to heroin-assisted treatment as a means of engagement. And remember that in Scotland, we're trying to increase the coverage of treatment to a much larger proportion of people with problem drug use. And I wonder if we should consider lowering the threshold for treatment now and bringing in people who at the moment might not want to approach services for the conventional oral treatment. I think the government has shown a lot of leadership. The new minister has shown a lot of leadership and some dedicated funding. As far as I'm aware, certainly in the United Kingdom, that's the first time that there's been dedicated funding for this sort of service. So I think it's about local ADPs and clinical services identifying their need and their potential as a model that would both work best for them.
Yeah, thanks, Saket. Carol?
Yeah, just to echo that, I think the public health needs assessment is the essential, and it's, you know, each area needs to do that individually to see what their needs are and what their population is that would benefit from this treatment. I think our short life working group had initially, part of the taking away the chaos, had almost every imaginable stakeholder. I mean, I think, you know, some of your colleagues from SDF were part of that group, and it was involving everyone.
Yeah. Danny, what's your thoughts on that?
Yeah, I think it's important that you've got the understanding of what's happening in the local environment, as has been already mentioned. I think it's key that we all remember, you know, that this treatment does work. It will be needed in those areas, and it's just a matter of ensuring that you've got the right level of provision for the potential need in your area.
And Scott or Eugenia?
Well, if I could just say, I am so excited to see a minister, an elected official, willing to support evidence-based care for people who use substances. We did have a Minister of Health here in Alberta, Susan Hoffman, who took a similar stand and was able to make some change and get some clinics opened. But I think that is key, that elected official support. I'm so happy for you.
That's great. Thanks, Scott. We would echo that, of course. Eugenia.
Yeah, just echoing and adding the piece, we have to look at this treatment as part of everything we offer, and make sure we start looking from the perspective of the client. Sometimes we just see injectables as this other extra thing out there. This needs to be part. If we don't make it part, it's not going to work. It has to be integrated and be these other things, so people can feel that when they are ready to start treatment, all these offers are there for them. They need to feel that we are there for them with whatever is available in our community, in our evidence-based, so we can serve them as they deserve.
Thank you. Austin, there was 4 other questions there. We've got through one, and we've got I think 3 minutes left or 4 minutes left. Do you want to choose the next one?
Well, the other one, I suppose, is the question of the balance of who makes the decision. So there's several questions in this about how first of all, what proportion of people might benefit from this treatment, and how are they identified? So, and is that decision made between the clinician, a prescriber, and the patient themselves, or what's the wider role for people who might be gatekeepers or budget holders and so on?
Okay, well that's part of the same point, really, I guess, about patient choice, isn't it, and about a range of options being available. Scott, do you want to come in on that one first? You know, in terms of what proportion of your client population you think could benefit from heroin assisted treatment at any one time?
We're only scratching the surface here in British Columbia and Canada, so we're not the model. I'm grateful that we've got our small number of pilot programs and what we do have. I think the Swiss are probably the furthest along in this, and they published sort of a natural state paper by NORDT a couple of years ago, and it looks to be about 10% of the people receiving an oral treatment that would require an injectable treatment like this. So that would be a good place to start and to look at.
Okay, that's great. Thanks, Danny.
Yeah, I would agree with Scott. The evidence tells us it's about 10% of the population that are on that will fail to benefit from traditional OST offers. So for Middlesbrough, we've got about 1,000 people in OST treatment. That gives you a guidance of about 100 people potentially who would potentially benefit from such a treatment.
Saket, you're smiling about what that would mean for Glasgow.
Yeah, I mean, we've done the maths and we've done the financial implications of that as well. So, I mean, just on the other side, and I'm not arguing on the other side, I'm just saying the balance that we have there is that it's a very resource-intensive treatment. And, you know, in terms of the best use of budgets, we've got to find a balance between using that high resource element of one part of our patient population and using other evidence-based approaches appropriately and optimizing them and making them as high quality and most as effective as possible as well. So while implementing injectable opiate treatment, you've also got to make sure that the rest of the system is working as best as possible as well. I think unless we're going to be given vast sums of money to spread all across the area. So I mean, to do those figures for Glasgow, we would need to have somewhere like 1,000 or to 1,200 people in treatment on injectable opiate treatment if we were to cover 10% of problem drug use prevalence.
Okay, thanks, Saket. You're going to have the last word there, I'm afraid, because we're out of time, and I'm conscious that we're running quite into the evening for our audience as well. So I'm afraid we're going to have to finish there. But thank you all for your contributions, and just if I can finish off with a few words around. You know, we've come to the end of this webinar, obviously, and it has been recorded and will be published on the SDF YouTube channel as soon as possible. SDF are aiming to establish a national working group for treatment stakeholders who are keen to develop and deliver heroin-assisted treatment services in their area. So please get in touch with us if you'd like to be involved in this group. So finally, I'd like to thank you all for attending this afternoon and early evening, and a special thanks obviously to the Minister for contributing to today's session, and all of the speakers, which I'm sure you'll all agree has been a very interesting and informative discussion, which will hopefully lead to further developments around heroin-assisted treatment. So thanks again, and goodbye for now. Thank you.
Thank you.
Thanks.